Okay, good afternoon, everyone. We will go ahead with our second talk on Heme Onc Emergencies. Those of you who attended the first one, it was more directed for the onc emergencies. And today, in part 2, we will talk about the hematologic emergencies and some, oops, which one makes the page go? Here you go, got it. That doesn't work. This doesn't move the slides?
Oh, you can, because it's a PDF, so you can use this.
Okay, here we go, thanks. So some disclosures. We covered in lecture 1 these entities. I believe I gave a copy of this, so if you had missed out lecture 1, you can always access them. In today's lecture, we'll cover some of the emergencies pertaining to benign and malignant hematologic disorders. I do mention supratherapeutic patient here in this, which is an important thing to cover, but it is a topic by itself, and I give out a lecture called Dealing with Coagulopathy. So we'll devote maybe a whole 45 minutes, another lecture for that, and we'll cover other things in today's session. So we'll begin with cases. I usually like to sort of get a point through a case. So this is a 73-year-old male presents to the emergency department with 3 months of headache, mental status changes in form of disorientation, agitation, inappropriate behavior. His wife also referred that he has complaints of decreased sensitivity of the extremities of the upper limb with burning of the fingers and progressive loss of autonomy. He used to be completely ambulatory and capable of activities of daily living. Now he's sort of seeming lost. He denies fever. There is no loss of weight or anorexia. There is nocturnal, there's no night sweats, no hallucination, and no seizures, no belly or chest pain. He also denies any alcohol, tobacco, or illicit drugs or herbal products. He has history of atrial fibrillations. He has had asbestos-related lung disease and benign prostatic hypertrophy, for which he takes a blood thinner and blood pressure medications. And he takes Lasix and Seroquel and lorazepam as needed. In an exam, he is basically disoriented to time, place, and person. He's got repetitive speech. His vital signs are normal, except for tachycardia of 118. His physical exam shows he's pale, has cardiac arrhythmias, and his he's got peripheral edema. He has no palpable hepatosplenomegaly or lymphadenopathy. His neurologic exam shows symmetric decreased pain to touch and heat in upper and lower extremities, symmetrically decreased muscle strength of the lower extremity being 3/5. His chest X-ray is shown. His fundus exam is shown, and he has his hemoglobin is remarkable for white hemoglobin of 8.6, normal white count, and his lab investigations show an elevated C-reactive protein of 58.44 and elevated ESR. His folic acid is more than 20, B12 is also elevated, serum iron is reduced, and he's got normal ferritin and transferrin values. TFTs are normal. BNP peptide is elevated, and he has basically a total protein of 7.6 and an albumin of 2.9 and an elevated beta-2 microglobulin. How do you read his chest X-ray and how do you read his fundus? Pay attention to those. There are some bunch of other values given out too, like his IgA being in reference range to slightly reduced. The IgM is increased, and his urine analysis basically shows some leukocytes. So with that all data, a complicated long case, what do you make of it? What is the likely diagnosis? We talked about SIDH in the previous lecture. Do you think it is colon cancer with anemia and CHF from anemia? Do you think it is hyperviscosity syndrome? Do you think he's got an ocular melanoma, or he has a mesothelioma with brain metastases? Complex case? So let's break it down. Let's look at the data given. The CT scan is normal. So brain mets is sort of excluded. So whenever in a complex case in real life or in boards, try to break it down. How can you rule out certain things? So, and then how many people would you see in CHF with 9 grams or 8.5 grams of hemoglobin? Hardly any, isn't it? Very rare for CHF to set in with that degree of hemoglobin. So with that picture, the likelihood of this being choice B looks unlikely. Brain mets not there. The fundus, what did it show? It's not showing any melanoma. It's not showing any masses. It's only showing some flame hemorrhages and some engorged vessels. So in a way, the diagnosis is there in the fundus exam. And then the fact that you got a slight cardiomegaly and it's got some interstitial spaces, but then in a patient with asbestosis, that's hard to decipher what is old versus new. But the answer is here in this red section here. There is hypergammaglobulinemia, and pay attention to the IgM level. IgM is a big molecule, and that adds up the viscosity. So this is a classic presentation of someone with hyperviscosity syndrome. And so that's the crux of this question. And yes, you could be waylaid. Each of these things looks probable. And when you don't know, like, okay, mesothelioma, maybe he's got lung cancer. So the history could be misleading at times, but it's the hypergammaglobulinemia. Now, when you are admitting such a patient, you'll get a clue from the gamma globulin section. And when your globulin section is increased, that's part of CMP. That should sort of raise your suspicion for this thing. Okay, doesn't this look like agitation, myostatus changes, breathing problems, cardiomegaly? Doesn't that all add up? Let me look at the fundus. And you look at the fundus, and you can probably make your diagnosis right there. And then you can always fine tune it. And you were given all the immunoglobulins that you get as part of the serum immunofixation. So that would be the next test to set, immunofixation and serum viscosity, which would probably be very high. And what do you do next? How do you treat these people? So whenever we see IgM excess, we usually call that Waldenstrom's macroglobulinemia. Whether it is, let's say, lymphoplasmacytic lymphoma, whenever the IgM is high, that's the cluster diagnosis we use. It could be because of a multiple myeloma too, but when IgM is increased, we usually call it Waldenstrom's. IgG, which most of the myelomas are, is a smaller molecule. So you need to have a really high M spike for you to get hyperviscosity symptoms. But since IgM is a pentameric molecule, even with small amounts, like maybe 4 times normal or 3 times normal, sometimes hyperviscosity syndromes can happen. You can have mucosal, just like you saw the fundic hemorrhages. That's what you can visualize on fundus exam. Same thing happens in your GI tract. So part of the anemia may not be a space occupying feature in the bone marrow. Part of the anemia, these people could have microcytic anemia too, because they're having basically bleeding from GI tract, from mucosal bleeding. And the CHF is from the enhanced plasma volume. And that's why the BNP peptide was elevated, and clinically was described with edema. And the treatment of these people is plasmapheresis. Now, this plasmapheresis is different from what you do for TTP, which you can also talk later in today. This is a plasmapheresis where you take out the plasma and give back only albumin. So you're getting rid of the globulin fraction. Whereas when you do plasmapheresis with TTP, you're taking the patient's plasma and giving back fresh frozen plasma or solvent detergent treated plasma. So plasmapheresis could be with different exchanges of the stuff you're using. Plasmapheresis for things like Guillain-Barré and hyperviscosity, it's about the same way. You take plasma, give back albumin. Whereas for conditions like TTP, it would be taking plasma and giving back plasma. So let's talk about another case. A 47-year-old female presents to the emergency room with fatigue, shortness of breath. She reports 2-week history of worsening exercise tolerance and has a rather sudden onset shortness of breath and for last few hours. And there is no major past history. She works as an architect. Prior to this illness, she has exercised 3 to 4 times a week. Her breathing appears somewhat labored on exam. You notice again tachycardia, tachypnea, and an erythematous rash on her chest and back, and a scattered ecchymosis on the extremities. Her lab results are given here. Her white count is basically slightly reduced. Actually, it's actually increased. It's 174,000. Her hemoglobin is 7.3 and her platelets are 24,000. So pancytopenia, other than the fact that leukocytosis. So anemia and thrombocytopenia and leukocytosis, and the smear is given to you here. This is the kind of smear you need to know for your boards. Like most others, it's for heme fellows to review it, but these are a couple of pictures which you need to know for medicine boards too. So what is the likely diagnosis? And the reason is you will admit these people. How do you, so the crux of the matter is there's leukocytosis. Either a leukocytosis, you need to act now, or it can wait till tomorrow morning. That's the question basically. So is your diagnosis acute leukemia? Is your diagnosis chronic lymphocytic leukemia? And is your diagnosis chronic myelogenous leukemia? Or you think it's just a leukocyte reaction from some infection which is brewing, or maybe some occult tumor she may have? So can anyone sort of find out what's showing up there? So if those of you who are new to this, like I welcome you to join our Heme Onc rotation. We'll show you smears. We look at patient smear most often in a clinic. But what you're wanting to see here is anything which has got a high NC ratio is a bad cell. And I'm going to pay attention to this and see how these large, bizarre cells are, at least in this high power field, I can spot 8 or 10 of these. Those are blast cells. So blast cells, pathogenomically acute leukemia, but also you could see these things in sometimes CML. So let's take a few pictures. This is a peripheral smear of CLL, and that's another thing which an internist should be able to recognize. Here, these are mature small lymphocytes. So how you use your yardstick in a microscope is your red cells is a yardstick. So your small lymphocyte is just bigger than a red cell. So these are uniformly similar to large cells, these are small lymphocytes. So this is CLL. So 174,000 CLL cells, don't bother me because they are not sticky. They don't cause any of the problems which I'm going to talk to you about in a minute. This is chronic myelogenous leukemia, where predominantly, if let's say the person had 174,000, majority of these would be still neutrophils, like maybe 40, 50, 60,000, 40, 50, 60%. But there'll be a few myelocytes and metamyelocytes, and rarely a blast may come up. And again, when a blast comes up, we are concerned about blast crisis. But again, the predominant cell type would be these guys here, which are the neutrophils, and not the premature cells as the preponderance as we saw in the previous slide. So we settle based on the differential looks, and in a leukomyte reaction, everything would be a neutrophil or things with toxic granulations and those kind of things. This is like a leukomyte reaction. You got a lot of Dolly bodies, these blue things here, a lot of activated granules in there. So those are sort of harbingers of leukomyte reaction. And usually you may have, usually the spleen size is normal, whereas splenomegaly would probably mean a myeloproliferative disorder, like CML. Acute lukes may not have a splenomegaly. So that's how the clinical exam helps. So why is leukocytosis bad? Because it can cause leukostasis. And what that does is the white cells can stick up in the microcirculation. And now think about another condition, sickle cell anemia, where red cells sludge up. So everything sickle cell can do, white cells are bigger cells, they can do even worse. So usually these are not seen. The blasts are more sticky and they're larger. So in acute leukemia, this happens more. Could it happen in blast crisis of CML? Yes. Does it happen in CLL? Usually not. You have to get like 400,000 white count for CLL to do that. Usually with 174,000 mature small lymphocytes, this is not going to happen. So where all the microcirculation worries us, lungs, brain, so respiratory failure, mental status changes. It could be anything from headache to frank confusion to being comatose. And it could be also focal. Sometimes it could be focal deficits can be present too. And how you treat these people, leukapheresis is ideal because you get a bulk of these cells you can examine under the microscope and get a diagnosis too. If you don't have an ability to do leukapheresis, this is something you cannot hold off a heme consult till next morning. You call it that very hour. And if whoever is answering the phone says, we'll see the patient tomorrow. No, you cannot. You have to come and give me an answer today. And if it's a place we cannot arrange leukapheresis at nighttime, sometimes we'll end up giving hydroxyurea. And certain conditions, like if these were on the looks of it, a promyelocytic blast, I may actually give other treatment like ATRA. So those are kind of things we start sometimes even before the diagnosis of what kind of leukemia is available. Those processes take some time. So another word, like usually doesn't happen for acute lukes unless the white count is above 100,000, but the myelomonocytic ones, they're more stickier because the blasts are bigger. So there I've seen symptomatic hyperleukocytosis even at 70 to 80,000. So 100 is a rough gauge, but sometimes depending on the size of the blast, that's why looking at the smear is so much more important in these things. And basically this is what happens in a pictorial way. And there is malperfusion. There could be sort of something, sometimes in boards you get a picture with something called the sharp burns. That means the fingers look like burnt. And that's also because something like purpura fulminans, but purpura fulminans is more acral and it's like skin involvement. This is usually at the digits. And such cases are a little bit hard to distinguish because many times there's DIC along with the acute leukemia too. So is it the DIC causing it or is it the leukostasis causing it? And the leukostasis, you do leukapheresis, this will reverse immediately. And at the same time, you want to check your fibrinogen level too, because for leukapheresis, you're supposed to put a big catheter in. And you don't want to put that when the fibrinogen is less than 100. So don't just focus on the white cells, focus on what could be coming along with it, like DIC2. I'm going to talk about that a little later in the talk too. So what could be the signs and symptoms? These could be pulmonary, respiratory symptoms of hypoxia, infiltrates on chest X-ray, dyspnea. It could be confusion, lethargy, vision changes. Sometimes you can see those sludging in the retinal veins if you're good at doing ophthalmoscopy. Fever is there, and usually there is acral ischemic symptoms, acral cyanosis, and renal dysfunction. And this is, by the way, a good sort of review paper if you want to understand about leukapheresis and hyperviscosity from leukostasis. Now, another thing, this person was anemic too, 7.4. You do not transfuse red cells to these people till you have the white cells control. So that's another thing to keep in mind. Don't transfuse them because that's only going to add to the viscosity. So you want to do leukapheresis first or cytoreduce them with cytoxan or hydroxyurea and only then consider transfusion because the mild hypoperfusion from anemia will not hurt them, but the increase in the viscosity could be really deadly. And these guys can stroke out if they have not before. Now, in some setting, if your hemoglobin allows, actually doing a phlebotomy helps because when you take blood out, This is places where you don't have leukapheresis. Here in Erlanger Hospital, you can get it ordered. But let's say you're in a small hospital, you're covering an urgent care somewhere, you can do manual exchanges. Take out a pint of patient's blood and give packed red cells back. So in a way, you're getting out a bunch of blast out and you're giving just the red cells back. So that's called manual judicious phlebotomies. And otherwise, you obviously do leukapheresis and you do hydroxyurea. Again, this is a good reference from blood from many years ago about how to manage these people with blast crisis or leukocytosis. And again, it's interesting. The gold standard of any procedure is overall survival. And since the overall survival of acute leukemics is balanced by the treatment they get for their leukemia, unfortunately, the apheresis or leukapheresis has never stood the test of overall survival. But it does show the morbidity and mortality to reduce in the first 1 week. And that's why it gets a category 2 indication rather than a category 1 indication when it comes to the apheresis guidelines. And now again, as I said, we can make these blasts mature with certain conditions like APL. So while you're also looking at the number, I would probably be the stickiest blasts are the myelomonocytic blasts. So AML, M4, M5, those are the most sticky blasts. There, I would do sometimes even with 70 to 80,000. And otherwise, APL, I can give a differentiating agent like ATRA and maybe make the cells better. ALL blasts are smaller and they're less stickier. So it's there sometimes you can go for a higher count. Today's day and age, now most fellows should know how to identify them. We don't have fellows here, so you'll have to ask us to come by and see. But if you don't have heme available, and if you do not know how to recognize these, flow cytometry is another way you can order. That way, these can be deciphered, and it can give you a head start. If let's say your hematology consultant is not available after hours, send a flow cytometry, and sometimes that would be reported early next morning and give you the answer. A word about APL, because we manage it a little bit differently, happens in young people. So that's why it's even more stressful, because young people, they die early. That's always bad, more mortality and morbidity there. They come a lot with hemorrhagic findings, and that's mainly because of the high preponderance of DIC with APL, and it's because these sticky blasts in the hour rods stimulate thrombin and activate the clotting cascade. Usually there's leukopenia. So these would be the ones which used to be labeled aleukemic leukemia. That means white cells are low rather than high. You wait a long time, the low white cells will become high white cells. So, and DIC and thrombocytopenia and anemia are mainstay of this. And why I need to worry about these? GIC, which can cause, again, this could cause an infiltrate, but this is a pulmonary hemorrhage. So if nowadays CT scans get done in the ER, so if you're reading hemosiderin in something, that's pulmonary hemorrhage. And that could be a clue. This is not infection, this is pulmonary hemorrhage. And same thing, that goes across the board for managing a person with low platelets and a pulmonary infiltrate. If there is an infiltrate and there's hemosiderin there, which a CT scan can decipher based on the house field markings, because iron has a dense house field markings and infection and water has lower ones. So you can make a distinction right in an emergency room scan. The response rates are very high with differentiating treatment like ATRA. So early ATRA helps. That's why we sort of give special sort of emphasis to it. This is what these blasts look like. Like if you have looked at this picture, and this is another smear which an internist needs to know. And basically what you're seeing are these structures here called hour rods. And this is like dense MPO positive granules. And there are some hour rods here. So these things, these long things are called hour rods. So if let's say you see it on a smear, or if your technologist reports it, most technologists can identify these blasts. And they'll say hour rod seen. Hour rod scenes get a hematologist to get their backside in at that very minute, because you need to start treatment for that. And what else would you do while you are waiting for a consultant to drive in from hematology? You would get a DIC panel. And we're going to talk about what is most important, but the most important thing is PT, PTT, and fibrinogen. You want to get them sent out, and the CBC is probably already sent. And then you probably want to make sure the lab makes a peripheral blood smear. That helps, because otherwise the hematology consultant comes in and they have to wait 2 hours for the smear to be made. So that's what you can facilitate for them. And oftentimes, because of the weird values, the lab would have made the smear anyway. So you call the on-call person and they will, this is something you want to act right away. Okay, let's change gears, talk about something different. Now is a 47-year-old male with no past history, presented with nausea, vomiting, and diffuse abdominal pain. He has a widespread rash which began 12 hours ago. And on physical exam, he's ill-appearing, diffuse abdominal tenderness. He's got a diffuse purpuric mottling of the skin, which you see here. And vital signs show that he's a little bit hypotensive, he's tachycardic, he's tachypneic, and he's febrile. And you basically find his oxygen saturation is low normal at 94%. He's you give him fluid boluses to try to raise his blood pressure. You have to put him on vasopressors as the blood pressure declines, and you put him on broad spectrum antibiotics. He is given steroids and you intubate him. Lab values show his white count is 12,700. Hemoglobin is 13.1. Platelets are 27,000. 26% bands, Dolly bodies, white cells, toxic granules. So I can refer you back to the leukemoid reaction smear. You see something like that in the thing. But this is not leukemoid reaction. There's something more there, isn't it? There's low platelets, and PT and PTT are both prolonged. And fibrinogen is less than 80. So what is the diagnosis? DIC. So that's what, now again, we talked about APL and DIC, but what do you think is going on? What is causing the DIC here? (103.7). So he's got, this is probably some kind of infection. This widespread rash was, have you ever seen a patient with fulminant meningococcemia? So there's a roseolar rash these people have. So that's what they were trying to say. And again, that roseolar rash gets changed into this purpuric sort of mottling of the skin because of dermal microthrombosis. So it changes in complexion. Nowadays, it's very good. People take pictures and say, hey, this is what it looked yesterday and this is what it is now. So that's something to keep in mind. So this is a case of meningococcemia where he presented with fulminant. Why do you get hypotension in meningococcemia? Not my forte, but because adrenal insufficiency occurs because of adrenal hemorrhages. So they are adrenal insufficient. That's why giving steroids is very important when you see this unexpected drop in pressure, because you can treat their DIC, but they also need good supportive care and treat them as adrenal insufficient. And you can check a cortisol if you want to be sure about it. So I'll introduce you to something called the ISTH DIC score. It consists of simple things you can get at the, in the emergency setting, a CBC giving you the platelet count, PT, fibrinogen, and D-dimers. Now, again, this is for non-surgical, non-obstructed patients. So these are not obstetric, and these are not, because your D-dimers are high in surgical and obstetric setting. And this is not valid in cancer either, because in cancer, your D-dimers are high either. So this is for run-of-the-mill medical ICU patients without any cancer, surgery, or obstetric complications. And you add up based on these numbers, and this is how you diagnose it. And this is not only a diagnostic, but also prognostic criteria. Because higher the score, the higher likelihood of the person dying in the ICU itself. So it becomes easy because, low platelets, low fibrinogen, it looks like DIC, but it is DIC. And that's why the objectivity is ususeful. And basically, thrombin is overproduced, clotting, Fibrin obstructs the small vessels, platelets and clotting factors get consumed. And that's why the platelet count and PT, PTT, and fibrinogen all go up. The PT actually goes much more up than the PTT. That's why in this, you did not see PTT, you saw PT in the ISTH guidelines. How may they present? It could be bleeding, it could be organ dysfunction. So 1/5 of the blood flow goes to the kidneys, kidney function can go up, liver function can go up, a mental status can go change. You can see schistocytes in the smear. So another differential for TMA, which we're going to talk in more detail later on. And a big distinction between TTP and DIC. In TTP, coags are never abnormal. That is the case which my colleagues discussed with me, who came in with HIT and then had low fibrinogen. So that's where I think it's sometimes difficult to decipher what is what. And so that's how you sort of look at the sequence and say with DICs more. And in the same patient, you can go from one to another diagnosis. And that's why serial follow-up of these numbers is very important. And what you need to do is treat the underlying cause is the main thing. And then if you have bleeding, only, mark my words, only if you have bleeding, you fix the coagulopathy. Do not empirically fix the coagulopathy. And because you could add fuel to fire and you get a clot, and you get a, there have been people where you've given cryoprecipitate without bleed down. If it's less than 100, you want to give it. Why? Because you could have spontaneous intracranial bleed. But let's say you've got 120, 130, it can feed the fire, and actually next thing you know, you have a sudden MI because something in the coronary arteries clogged up. And again, a lab question regarding it. The most helpful lab testing in DIC is which one? A D dimer elevation, PTT, which is decreased, fibrinogen, which is elevated, prothrombin, which is prolonged, or FDP, which is diminished. So we just, the right answer is D, because fibrinogen should be low, and PTT is not part of the parlance, but the PTT should be prolonged, not decreased. So simple question that way. So this is another way of looking at, usually PTT is prolonged, but most often PT is prolonged, platelets are low, and fibrinogen are low. And then schistocytes may be present, D dimers may be elevated. They are corroborative, but they are not required in a diagnosis other than like when you're trying to run the DIC score, because D dimers are very ubiquitous. They are high in many other things too. The commonest, what do you want to do in the middle of the night? You want to hemodynamically stabilize the patient. That's why giving steroids to that meningococcal patient was important. You treat them with antibiotics. Those are most important. And now, if your platelets are less than 10,000, there's risk of intracranial bleed. With fever, that number gets raised to 20,000. So you want to maybe correct the thrombocytopenia based on the scenario. That patient had 27,000 platelets, so I would probably not give transfusion to the patient we discussed. An aggressive resuscitation with colloids, because what happens? There is vasodilatation. So you need a lot of colloids and crystalloids to be given to control the pressure. You pan culture them. You need to intubate them and hyperventilate them. Because of what? Because lactic acid is going to accumulate because of the not only the peripheral circulation being blocked up, but also because of the blood pressure falling out. And that's why sometimes have to compensate with respiratory means. So let's take another question. A 19-year-old female complains of weakness and fatigue. 2 weeks ago, she saw her family doctor and was diagnosed with URI. She received no medication at that time because they thought it's probably a viral infection. Physical exam shows scattered petechiae, and she's got some sort of areas of clothing which has got pressure. There the petechiae are more. And the lab studies show white count to be maybe slightly elevated, mildly anemic, and platelets are 16,000. PT and PTT are normal. This is her smear. What is the appropriate diagnosis? A, TTP. B, acute promyelocytic leukemia. C, DIC. D, ITP. So large RBC size platelets. Now, I know you guys don't have access to smear views. In most residencies, I think you should have ability to see smears, but I find it myself getting a smear made in an act of Congress. It takes 2 hours to get a smear made. So that's why I said, if you're calling me, make sure a smear is ready for me in the lab. That'll save time in making a diagnosis. So before you see the smear, MPV is your clue. Usually your MPV would be 10, 11, 12, 13, 14, something above 10. That's what large platelets mean. What does large platelets means? Bone marrow is not a problem. Young platelets are large in size. So here consumption is a problem. Now, everything listed here, except for maybe acute promyelocytic leukemia, you could have consumptive thrombocytopenia. But there's no schistocytes. That's why A is off. Coags are normal, so that's why DIC is off. And we don't see any blasts, so that's why probably APL is off. The definition of ITP does not need any magic tests. ITP is diagnosed with a normal CBC with isolated thrombocytopenia, with a normal smear with large platelets, but no schistocytes or other aberration, and no splenomegaly. That's the simple American Society of Hematology diagnosis of ITP. So you don't need to do an ANA, you don't need to do a platelet antibodies or anything. It's a clinical diagnosis by excluding all these other entities. So a normal platelet count is 150,000. Anything less than that is thrombocytopenia. Bleeding seldom occurs with consumptive thrombocytopenia unless the platelets go below 20,000. Why? Because these are large platelets. So you got enough platelet mass in there. Now, many infections masquerade as ITP. That's why ASHA guidelines say whenever you make a diagnosis of ITP, exclude HIV, hepatitis C, and a third one, which is also customary, is Helicobacter pylori, because all these three things can masquerade as ITP, and treating the antigenemia usually helps reverse the thrombocytopenia. So HIV, you give antiretrovirals. Hepatitis C, you treat with the Hep C, that get better. But there is an entity of ITP with Hep C, and I wrote the first papers back in 2000 on that. And that's why ASH adopted Hep C in their screening pathways for ITP. Now, again, I may pay emphasis on the words normal spleen. Why? Because portal hypertension from cirrhosis can also masquerade like this. There would be a low platelet count. So acute alcoholism can do that. It can cause a toxic effect on the platelets, but that's why we remark on normal other lineages. Alcohol will usually cause macrocytosis as well. And on the smear, you may see target cells. So that's why history, smear, lab values, they can usually help you make a distinction. Bone marrow may not be very useful in ITP because you expect megakaryocytes to be normal and it will be a hypercellular bone marrow. So if you do bone marrow in some people, you're trying to exclude something else like CLL. CLL can cause a secondary ITP. So that's one thing. You see lymphocytosis, and you want to make sure if it just maybe a viral infection lymphocytosis, or maybe this CLL and ITP. So there it may be useful. MDS, that is another thing we sometimes worry about, and maybe the hemoglobin is a tad low, like not maybe like 10.8 in a female or maybe 11.2 in a male. It's not normal. So again, by ASH definition, the rest of the CBC was not normal. But so usually, customarily, if someone is more than 65 years of age, before we venture a diagnosis of ITP, we do a bone marrow in such people. And again, in your differential, you can have everything else. HLH, metastatic carcinoma, lymphomas, myelomas. But again, that's beyond the scope of today's talk. We think about all those things, but in an acute emergency, ITP is what we're going to manage. And again, why looking at the smear is important? Because there could be pseudo thrombocytopenia. You guys are familiar with what that is? Like it's, and how you can decipher is send a platelet count and citrated blood. Now, I just learned it 3 days back. Then Erlanger stopped doing it. And I've already written an email to the lab people. That's the simplest test you can do when you cannot provide a smear to me in less than 2 hours. So, but they may reinstate that, but that would have been a good way of deciphering it, a citrated tube CBC. That would get rid of the pseudo thrombocytopenia, because that's because of an EDTA antibody, and it's more of a lab artifact than a real problem. And usually these people are not bleeding. So you'll see a 30,000 platelet count and not a speck of bruise on the patient's body. That's why correlating symptoms with lab values is very important. So a word about hemolysis, which would lead on to our next topic of MAHA, or microangiopathic hemolytic anemia. This is what hemolysis is. Something breaks down the red cells, and then you see either the spillover effect of the internal domains of a red cell, like LDH going up and the heme being released, so plasma hemoglobin go up, or you may have the haptoglobulin go down, or bilirubins go up. And schistocytes are the broken pieces of these red cells. And the red cell breakdown per se also activates thrombin. So it's a chicken and egg situation. Did the red cell breakdown cause platelet aggregation and activation and thrombin generation and DIC, or DIC caused thrombotic microangiopathy? That's like always a situation we have to decipher. And how we reach most of these clinical syndromes are in true thrombotic microangiopathy, where we tend to include TTP, HUS, and AHUS. Now, again, all three in details is a whole talk by itself. So we'll sort of touch up some of the emergency points there. When you're suspecting there, that's another reason you want to call hematology early, because early plasma exchange saves lives. So what are the hemolysis labs you'll do? You'll probably do haptoglobulin, LDH, bilirubin, D-dimers, PT, PDT, fibrinogen schistocytes, because that's going to help you decipher DIC versus one of the other things. Looking at the smear is important, because I'm going to talk in a minute how megaloblastic anemia could give LDH elevation too, and pancytopenia too. And megaloblastic anemia due to severe B12 deficiency can cause homocysteine to go up, which can cause microthrombi, and sometimes true TTP can occur also in that setting. And there you do not need plasmapheresis. Giving vitamin B12 is the answer. So it's a very underappreciated TTP, but keep that in mind. If you see a big MCV, which is like not just big because of reticulocytosis, B12 levels can come back in 2 hours. So check that. If it is low, give a B12 shot. That's probably going to solve the problem before you start talking about plasmapheresis. Rare, but not to be forgotten. So here's an algorithm for workup of thrombocytopenia. Again, this is a good paper from Stasi, which appeared in Hematology, which is one of the blood journals a few years back. So you want to examine the smear. It's very important. And obviously, history is important. In young ladies, sometimes, oh yeah, by the way, my mom and dad also have low platelets. So that's important. They have giant platelets too, and they have Dolly bodies, like I showed you in the leukomoid reaction smear. That's what you see in things like May-Hagelin anomaly and such things. You examine the smear, rule out pseudothrombocytopenia. It is true thrombocytopenia. You rule out abnormal inclusions, and then you want to see, are there schistocytes? Are there blasts? Are there microspherocytes? That could give you a clue for what? Evans syndrome, autoimmune hemolytic anemia with ITP. Is there lymphocytosis? Could this be a reaction of infection, DIC, and maybe related thrombocytopenia? Or it is truly an isolated thrombocytopenia without any of those things. And this is what we talked about earlier, ITP, and you want to rule out infections. And each of these things, we talked about leukemias. This is, you do a Coombs test and get a diagnosis. And this, you want to get hemolytic markers, and you're working with a bracket of either TTP, AHUS, HUS, and that kind of thing. And I think if we have, we'll talk about TMAs in more detail some of the time, but schistocytes, this is what you want to see. This is called schistocytes, or helmet cells, or the German helmet cell is another name for them. And this is the clinical what purpura looks like. In ITP, you have basically consumption of platelets. In TTP, basically, there's consumption of platelets and there's lack of the enzyme called ADAMTS13. What does that enzyme do? It chops up 1-villiminant factor multimers. So in the absence, large 1-villiminant multimers occlude. They're called Weber pallet bodies, and they activate platelets, activate thrombin generation. You lay out these shards in the peripheral blood, which sort of chops up the red cells. And the platelets are consumed because of these clot formation. And very high mortality untreated. You treat plasmapheresis and you follow up LDH in follow-up of these patients. Now, how are you going to distinguish this? You're going to check the labs we talked about in DIC. And for DIC, basically, you will have a abnormal coags. In ITP, you will have, only basically the coags would be normal. So other things besides the TTP and its close cousins in TMA, obviously in acute sickness, DIC, sepsis, malignant hypertension. Now, another thing, captopril renal syndrome, something talked about a lot in the boards, that can look like TTP in lab values in the smear. Malignant hypertension. Now, having said that, preeclampsia and eclampsia in the pregnancy setting, that's another one. You may get a consult from OB, hey, this lady had eclampsia, we delivered the baby, she still has high blood pressure, come and take care of her because now we have the baby out of it, it's your problem now. Common consult in this place or no? Used to be very common problem in Memphis. And and there it is interesting because TTP has a higher predisposition in peripartum phase, so does AHOS. So or it could also be defibrillation syndrome. So all these three things come together in that peripartum phase. So deciphering them methodically is very important. Again, there is something called veno-occlusive disease of transplant. All those things are close cousins. This is the vitamin B12 deficiency I was talking about. So those are things to consider. Certain chemotherapy agents like gemcitabine cause thrombocytopenia, TMA, cyclosporin, Plavix, all those drugs can cause thrombotic microangiopathy. And those are irrespective of ADAMTS13 deficiency. So in those things, ADAMTS13 may be normal. So a multifocal etiology for TMA, and that's why when you talk about TTP, I'm looking at all these other things which may be going on. And only the cell, where does plasmapheresis work? Usually in getting rid of the antibody and supplying the ADAMTS13. So it's only in that where plasmapheresis works. Sometimes it helps because there is a similar mechanism in HUS, and sometimes it works also in chemotherapy and induced TMA. So that's the thing which we give while we're trying to define the diagnosis. And so let's take another case. So 40-year-old female is brought in by her husband because of 24-hour history of slurred speech and confusion. She's unable to provide any more history. Her exam has scleral icterus, multiple ecchymosis on both limbs, both upper and lower extremities. And these are the lab values. So hemoglobin is 9, white count is V-bit elevated, platelets are 28,000. This is the smear. And her creatinine is 3, bilirubin is 5.7, LDH is 986 with 240 being upper limit of normal. And the prothrombin time is 11 seconds, PTT is 31 seconds, both being normal. And what do you do next? A, eculizumab, which is like a C5 antibody. B, plasmapheresis. C, plasma infusion. D, platelet transfusion. E, prednisone therapy. So we just talked about, it's a tough question, so let's break it down. This is not isolated thrombocytopenia. So this is not ITP. So E is out of the question, okay? What do you see here? Schistocytes. This is thrombotic microangiopathy. The creatinine is elevated and the LDH is elevated. Now there's a small poll here, which only hematology fellows are told. You guys are not leaked that secret. It's called a ratio between creatinine and platelet count. So usually in TTP, the creatinine is not affected that much, the platelets are affected more. So if your creatinine was more than 1.4 in a female and 1.8 in a male, and the platelets were more than 20,000, it's more likely to be AHOS. Here, you don't meet that criteria. So here, it is more likely to be TTP. So this is just like, this doesn't hold valid. So you cannot say, hey, the creatinine was normal, so why, how come this is not TTP? Why are you calling it AHOS? Again, ADEMTS13 is the answer. That's the gold standard. But ADEMTS13 takes what? It takes 2 to 4 days in this hospital to come back. So till you get that, it is a slash diagnosis, TTP/AHOS/HOS. HOS easy to rule out, sugar toxin in the stool or a history of diarrhea. But other things, so where in doubt, do plasmapheresis. Why? Now, before that, let's talk about something called plasmic score. Now, this is a score which has been validated at some sites now. It's not still mainstream medicine, but something I would recommend you guys can do in the middle of the night. And that's basically looking, it's again, putting into perspective the practice points I said. Platelet count of less than 30,000 gets 1 point. Hemolysis gets 1 point. No active cancer gets you 1 point. Solid organ transplant absence gets you 1 point. So basically, you're excluding other causes of TTP where ADEMTS13 is usually normal. And then you look at MCVY because that rules out what? B12 deficiency and liver disease. And creatinine being less than 2. So they made the 1.8 to 2 just to be more on the safe side. So if you have a high score, you got a higher chance of ADEMTS13 deficiency. So that's how it is useful. It helps give you, so if you have a score of 5 or 6, a very high likelihood this is TTP, and plasmapheresis should be probably commenced in that setting. Now, why did I say that? Because without plasmapheresis or plasma infusion, mortality was 95%. And this is what happens with plasma exchange. This is what happens with plasma infusion. Plasma infusion, your volume is restrictive. You can only give X amount of plasma infusion, otherwise you get volume overload. In exchange, you can give up to 2.5 times volume. So you can get rid of patient's antibody, give more plasma, which doesn't have any high molecular weight von Willebrand factor, and you're supplying that ADEMTS13 from outside. That's how plasmapheresis works. And this improves a 95% mortality to nearly an 85% survival. So that's a game changer. That's why it's an emergency. Now, this is just to give you a rundown of what, and if we dedicate a talk to TMA, we'll talk more in what these things are, how these acquired things happen. And I think we talked about once you get at ADEMTS13, 5 to 10% is considered the cutoff. Then you have TTP, and then you have basically, there are few TTPs. You add Kablivi, which is an antibody for von Willebrand factor. You're going to get a heme consult, so don't bother yourself with those fine details. This is the pathophysiology, which we sort of talked about already, so I'll skip that. Now we go to another question. 60, now those slides I'm skipping through, they're still important reading materials, so go through that. I'm just in interest of time going over them, and if we do get to give another talk on TMA, we'll talk about each of those points in more detail. So here's another question. He's got 68 years of age, headache, dizziness, blurred vision. That's been the common theme in all of our patients, isn't it? And this guy's blood pressure is very high. He's got florid facial, a plethoric face, a normal fundus, marked splenomegaly, hematocrit is 67%. What do you recommend doing for him? A, salt poor albumin. B, intravenous nitroprusside. C, phlebotomy. D, plasmapheresis. E, sublingual nifedipine. So A, wrong answer. B, okay, but this is not just malignant hypertension. So that's not going to be a home run there, isn't it? You can do whatever you want, and I don't know if nitroprusside is the best idea in 2022 for controlling blood pressure, but this is from straight out of the boards. So AB, I'm still asking you on these questions. So Maybe they put in nitroprusside because no one's going to use it for controlling malignant hypertension. Do you guys use it anymore? Once in a while. So plasmapheresis, I don't see any indication for. Yeah, he seems to have some kind of symptoms of hyperviscosity, but this is a hyperviscosity not because of serum proteins, but because of what? Formed elements of blood. So this is some kind of myeloproliferative disorder. And with those symptoms, I don't care whether it's primary or secondary erythrocytosis. I'm going to phlebotomize him. So even if this is a guy with COPD with secondary erythrocytosis, at that level, it's giving him symptoms. And the red cells need to come out to seize the right answer there. So how phlebotomy is done, you take out 500 mils, like 2 gravity. So you're not sucking it, you're doing it by gravity. It's just like donating blood. And then you may or may not need to replace volume intravenously or just orally. The next maybe 3 minutes which I've left, I'll talk quickly about sickle cell. Again, sickle cell is a topic by itself, but I'll try to communicate some sort of pearls for veno-occlusive crisis, not really a crisis in my opinion. Hydration, pain control, that's the mainstay. And oxygen sometimes. What are the emergencies? Acute chest syndrome. And what is the definition of acute chest syndrome? New infiltrate, fever, symptoms, which could be cough, sputum, dyspnea, and hypoxia. So when you have this constellation, think about acute chest syndrome. It could be from fat embolism, it could be from marrow ischemia, it could be from pulmonary vasoocclusion. And you want to break the tide of vascular constriction and venostasis from red cells. So how you treat it? In children where basically the symptoms are more acute and they can be far-reaching, you usually do exchange transfusion. In adults, you can give a trial of other things like simple transfusion before you resort to exchange transfusion. You want to at the same time treat the infection, and depending on the severity, like if you're very hypoxic and the patient has already got 10 grams of hemoglobin, you're going to make them hyperviscous by giving transfusion. So if they've got like 7-8 grams of hemoglobin, you can give simple transfusion, see if they get better. And how you choose they're getting better is symptomatically less chest pain and the oxygen saturation goes up. Then you can stop there. But if it is not improving, or if the hemoglobin is already 10 grams, you need to do exchange transfusion. A splenic sequestration, if none of you are med peds, I will not spend too much time there because this happens in kids and adults. The spleens are already infected unless they have sickle beta thalassemia. So more so in sickle beta thalassemia, splenic sequestration can be a problem. We'll skip it, it's there. Aplastic crisis, suddenly severe anemia away from the baseline, usually happens from infections. Parvovirus is the big culprit there. Why it's important to identify, again, supportive care, you give transfusions, but sometimes giving IVIG helps shorten the course of the sickness. Hemolytic crisis, I have a lecture on hemolytic anemias we'll cover in there. So this is the important part, aplastic crisis, parvovirus, that's the answer there. And I did not include stroke in this because stroke presents much like acute chest syndrome. And again, the indication is acute exchange transfusion, but it usually happens in people who are 14 years of age and or younger. So all of you, I take it, medicine, not med peds. So you'll probably not see it in your medical domain. So that's why I skipped that in interest of time. Well, I ended at 1. So any questions? Good. So no questions mean either I was very clear or you didn't understand anything. So which one is that? A or B? So anyway, I think you keep these things in some kind of shared drive. So any questions? I'm on Erlanger and UTHSC email. You can always drop me an email and I can clarify. Thank you.